my dear colleagues. Welcome at the academic platform Onco Ocean. Myself, Dr. Aditya Patel, DNB final year resident at Apex Cancer Institute, Varanasi. So, in this series, moving forward, here we are with yet another interesting talk. For today's session, I feel honored to invite our speaker, Dr. Kanika Sood Sharma, ma'am. Ma'am is director and clinical lead at Dharmshila Narayana Hospital. Ma'am has done MBBS, and she's been honored as gold medalist. Uh, she's completed MD Radiation Oncology, post which she has done a course in hospital management from IIM Bangalore. Ma'am has special interest in gynae onco, GI onco, breast malignancy, stereotachy, and preventive oncology. Welcome, ma'am.
Thank you, Aditya.
So, ma'am, today we'll be speaking on the topic PMRT in 1 to 3 node positive cases. Like all intermediate risk patients, do they need post-mastectomy RT? Over to you, ma'am.
So thank you, Dr. Ankita, and thank you, Dr. Aditya. And I would, firstly congratulate you for this entire set of series, and also would want to, really commend that you have been selecting very pertinent topics. The topics which you have covered so far have been elaborate, starting from the very basics. And then, of course, coming to topics like today, where, a lot of things are still not put to rest. There are a lot of controversies, and we still have ambiguities. But however, I think 2025 has seen a lot of robust data come in from two big studies. So it definitely is a very good time to discuss the role of post-mastectomy radiation therapy in the scenario of 1 to 3 lymph node positive cases. So we would try to, comb through the existing literature and see how things have evolved in the last 2 decades, and also what now should be our approach. So I'll be covering firstly, very briefly, why we should be doing post-mastectomy radiation and why the need of treating chest wall in 1 to 3 lymph node was determined, and how evidence has evolved. And then, as I mentioned, we'll comb through the current evidence to identify who needs to be given radiation in the intermediate risk factors. And additionally, what I felt is important, because nowadays we are in an era of systemic treatment being used more and more often in the neoadjuvant setting, even in early breast cancers. So where we can fit in the PMRT in the same scenario after NACT. So this would be the overview of what we will cover today. So firstly, I think you need to understand that post-mastectomy radiation has been crucial in adjuvant setting in breast cancers. We all know for high-risk cases. However, even in intermediate risk cases, the incidence of locoregional recurrence as well as the breast cancer mortality has been affected by usage of PMRT. And there has been benefit, though the benefit has varied across studies and has been changing with the integration of newer systemic treatments in the last 2 decades. So there are, guidelines giving you an individualized decision-making approach, saying that it is the shared decision-making era where you have to discuss with the patient when you're using radiation in intermediate risk factors, what would be the benefit versus what would be the sequelae. So these are the additional things which current guidelines, especially the ASTRO-ASCO guideline, has suggested. And the ongoing SUPREMO trial, although they've given their 9.6-year follow-up data, have now tried to give you subgroups which could be benefiting from the PMRT. So these in general, for the sake of our residents, are the indication of post-mastectomy radiation in breast cancer overall. These would include even the locally advanced breast cancer. So any patient who has more than 4 axillary lymph nodes, has T4 disease, T3N0 disease, and even 1 to 3 positive lymph nodes where there are additional risk factors such as young age, LVI, high grade, positive margins, and residual disease after neoadjuvant systemic treatment and positive margins. These are the established PMRT indications which we have been using in our clinics so far. So how we came to the understanding that nodal disease is of importance. So the combined analysis of these two big studies, the NACBP-B18 and the B27, found that locoregional recurrence is hugely impacted by 3 factors. Firstly, whether there was a lymph node positivity upfront, what was the tumor size, and how the patient has responded to NACT. So if you look at these two panels, on the left side is the cumulative incidence of local recurrence in patients who have tumor size less than 5 centimeters. On the right side, there is the LRR data of patients who had tumor size more than 5 centimeters. So in the both panels, you can appreciate that patients who had lymph node positivity upfront or who had lymph node positivity after NACT, there was higher incidence of local recurrence compared to patients who did not have lymph nodes upfront. So the breast as well as the nodal CR were determinant for local regional recurrences. So lymph node positivity has a huge importance. Mostly all the data which came for PMRT, which has been the backbone of our practice so far, have been these 4 trials. Firstly is the British Columbia study, which was done for the LABC's years follow-up, where they have determined that the addition of radiation after MRM has improved overall survival as well as local recurrences. In even the DBCG 82B and 82C, which was in the premenopausal and postmenopausal women, has shown that in the era where CMF was practiced, there was a significant benefit of adding RT to the MRM. The EBCTG meta-analysis, which came in 2014, they further segregated these patients into patients having no lymph nodes or having pathological positive lymph nodes to the tune of 1 to 3 or more than 4 lymph nodes. And they came to a finding that the 10-year outcomes as well as the 20-year outcomes of local regional failure and overall survival are indicating that there is a benefit of addition of PMRT in both the 1 to 3 lymph node subgroup as well as more lymph nodes, more than 4 lymph nodes. As you can see highlighted in red color, the 10-year outcome of local regional failure, patients who received RT had only 3.8% local failure compared to 20% who did not. And when it comes to more lymph nodes, the value shooted up to even 32%. At 20 years, the overall survival again was reflecting an trend towards improvement by addition of post-mastectomy radiation. So for 1 to 3 lymph nodes, we have data set from these 2 big studies, the EBCTG meta-analysis as well as EORTC, where they have reflected that there is a profound, almost 16% benefit of addition of PMRT. So for the understanding of what has happened in the last 2 decades, I have just created this timeline. I think in a snapshot with this timeline, you can understand how the lymph node RT studies have evoluted in the 20 years, and majorly the guideline changed after the 2005 study, which came from the EBCTG meta-analysis, wherein this is a study by the Overgaard couple where survival benefit was observed in patients who had even 1 to 3 lymph nodes. And it was the starting point of an international debate where people started to understand the importance of 1 to 3 lymph nodes. So contributed to this was few more analysis, the Tendulkar et al. Study and some more retrospective studies, which led to NCCN include PMRT as a recommendation in 1 to 3 lymph nodes also in the high risk categories where there are T3 tumors, LVI or a younger age. So you would see that when you follow the NCCN guidelines 2008 onwards, this strongly considered radiation line was incorporated. Further on, in the coming 7 years, the sub-analysis of the Danish and the British Columbia study also showed that the benefit does continue in this subgroup. Although the subsequent studies do also say that instead of anatomical selection, it is the biological risk-based selection, which is a more wiser option when you are choosing whom to give radiation in the intermediate risk category. Subsequently, in 15, the DBCG 82C update also reinforced the fact that local regional control and overall survival in these selected 1 to 3 lymph node positive patients remains to be there. So it is somewhere in 2017, 2019, when the SUPREMO enrollment also started, that you began to understand the impact of biological risk factors and the oncotype and mammoprint started to influence the decisions on systemic treatment, and people try to extrapolate whether such algorithms or normograms or these genomic analysis can impact the PMRT. There are few studies in early, but we still await biological risk stratification based upon the molecular markers in post-NACT and the early risk breast cancer patients. So by 2022, it became like not a paternalistic practice. It is the shared decision making that in these category patients, the intermediate risk category patients, based on risk stratification, if you are choosing to radiate in 1 to 3 lymph node setting, you have to have the patient as a part of the decision making and try to de-escalate where patients are of low risk. So even in intermediate, trying to segregate into favorable and unfavorable approach is what was suggested in these studies from 2022. And now in 2025, as we stand, we have certain results coming in from the SUPREMO, the BIGO4 study, and the NRG, NACT studies have also given some results in this year, which I will be discussing in more details in the coming slides. So key question for today is, do all intermediate risk patients, that is T1, T2, 1 to 3 lymph node positive, require post-mastectomy radiation therapy? So evidence is saying selective. So how to select is what we would try to analyze through this study. So now I'm going back into timeline to 2005. So let's start a little bit detailed analysis of the first 2005 study, where we started to debate on 1 to 3 lymph node radiation. So in this study, almost 1,100 plus patients who had at least 8 lymph nodes removed and positive were randomized to post-mastectomy radiation or no radiation. And majorly, 2 subgroups were divided: more than 4 lymph nodes and less than 4 lymph nodes. So it was found in this particular study that even at 15 years of follow-up, patients in the 1 to 3 lymph nodes category had an absolute benefit of around 9% when it came to locoregional recurrence or when it came to overall survival. So there was a 9% benefit observed for the locoregional recurrence in the 1 to 3 lymph node category, as well as the more than 4 positive lymph node category. For the overall survival also, it was found that 5-year benefit was found, and the relative risk reduction was to the tune of 87% in 1 to 3 lymph node positivity. So to understand that, how many patients you would need to treat to save one life, it was found that in 1 to 3 lymph node category, if you treat 5 patients, you are saving one life, or you're reducing one risk of one locoregional recurrence, and you need to treat 11 patients to prevent one death in 1 to 3 lymph node categories, which was not much different from more than 4 lymph nodes. As you see, 4 patients needed to be treated for 4 plus lymph nodes, 10 patients needed to be treated for more than 4 lymph nodes. Additionally, what they found that there is an impact of the primary tumor size as well, and the benefit in the survival was more pronounced in tumors which were smaller, whereas locoregional recurrence benefit was more pronounced in larger tumors. So this was the understanding of this particular study, and therefore they went on to recommend that the guidelines need to be modified into 1 to 3 lymph nodes category. And it is not just the lymph node count as such, that is not just the more than 4 lymph nodes or high nodal ratio, which should be a stratifier for adjuvant treatment selection. So this is the incorporation which came in, and it is still seen in the 2024, where 1 to 3 lymph node, axillary lymph node positive after a mastectomy in T1, T2 tumors, one is recommending radiation therapy to the chest wall, as well as comprehensive regional lymph node irradiation of undissected axilla at risk as well. So further on, there were some retrospective studies which again were trying to understand the impact of modern systemic therapies, because from CMF we have evolved to much more efficient, more effective systemic therapies. So this study was conducted from 2000 to 2007, again in the same category of 1 to 3 lymph nodes. And what they found is that the locoregional recurrence at 5 years was 0% in the PMRT group, whereas 8.9% in patients who were receiving radiation. On the univariate analysis, the risk factors which were identified for local recurrence were primarily the hormonal status, LVI, presence of more than one lymph node, high nodal ratio of more than 25%, extracapsular disease, and grade 4. But on multivariate analysis, it was extracapsular disease and grade 4, which was deemed to be of most importance. So for risk stratification, they could see that when a patient has both grade 3 and ECE, the local regional recurrence can be to the tune of 50%. So risk stratification based on these biological factors which was the main merit of the study, which could be one of the guiding points in our case selection. So moving to some other parts of the world, because we had a lot of data coming from Europe, even the Japanese analyzed their data set from the Japanese National Clinical Database in this case scenario of 1 to 3 lymph nodes. This again, it's a retrospective cohort study which was conducted from 2004 to 2012 and had around 9,000 patients. And they had included all patients with mastectomy with lymph node dissection. The patients who received radiation were around 5.5% of this entire subgroup, that is 492 patients, versus a big number of 94.5% who did not receive radiation. They followed these patients for 6.3 years. And what they found was that they did not find any significant association of local regional recurrence based on PMRT. However, they do find that it is the parameters such as the tumor size more than 2 centimeters or more than one lymph node and triple negative subtype, which have a higher risk of local regional recurrence. If these are the subcategories which are there in your patient, then that would merit towards getting PMRT versus not getting PMRT. So they could identify 3 risk factors here. In the subgroup analysis, as I mentioned, they found that in 1 to 2 lymph nodes, they did not find much benefit. For 3 lymph nodes, they found a trend of improvement. And the reason probably why these local recurrences were going down, because the modern chemotherapeutic drugs and refinements in surgical procedures was also going on parallelly as the radiation was progressing in techniques. So they concluded that if you are to be considering PMRT, the subgroup for high risk would be larger tumors, 3 positive lymph nodes, or triple negative patients. Similarly, another study from Korea, they tried to do a propensity score match analysis in their patients, trying to identify the benefit of post-mastectomy radiation in this subgroup of 1 to 3 lymph nodes. This again remains to be a retrospective analysis, and they did around 8 years follow-up, and they found that the PMRT versus non-PMRT, they did not find any significant change in local regional control DFS or OS. However, their rates of lymphedema were very high in the PMRT group, and which reached a statistical significance. So what additionally they've mentioned in their study is that though more than 3 lymph nodes and LVSI should be associated with lower local regional control DFS and OS, but in their study they did not establish this finding. So they went on to conclude that they did not find a clear benefit of PMRT and rather found a higher rate of lymphedema. So they are considering they're recommending considering omission of PMRT in low risk categories and individualizing. So another study from Korea itself, which again was a retrospective analysis. Here they tried to compare BCS with RT versus a mastectomy without RT in this subcategory of patients of 1 to 3 lymph nodes. So what they found was that it is the younger age and higher grade and hormone negativity which was affecting their outcomes, and addition of RT in BCS actually was helping in a reduction of local regional failures, disease recurrence, as well as improving the overall survival. As you can appreciate in this table, the BCS group fares pretty well, although it did not reach statistical significance in comparison to only mastectomy with no RT. So they feel that adjuvant RT as a part of BCS was lowering the local regional and distant recurrences, and survival benefit in 1 to 3 lymph node positive category. However, such studies, we cannot take them as, a starting point of changing guidelines, because these are retrospective, and I think I forgot to tell you the case selection. If you see, the volume of tumors was varying in these two groups, as well as the usage of systemic treatment, and the patient age group was also differing in these two subgroups. So effectively, there were, a lot of editorials also coming in parallelly up to 2021, 2022, where post-mastectomy radiation was considered to be continued to be used in absence of the prospective data coming in, and the data which we already have in hand is already level 1A. So this one editorial by Pootsman says that we have to use PMRT, considering that there is a reduction in local recurrence as well as the breast cancer mortality. However, then came the prospective SUPREMO study, and this is a very big multi-institutional study, which is spanning across 136 centers in 24 countries. It is selective use of post-operative radiotherapy after mastectomy, and the objective was to compare the benefit of radiation in the chest wall in intermediate risk category patients. So they took patients who either had, T1, T2 disease with N1, or T3 disease with N0, or T2 disease N0, but with grade 3 histology and LVSI. So they randomized the patients into chest wall radiation versus no chest wall radiation. And endpoints of the study was to see the effect on overall survival. Secondary endpoints included disease-free survival, toxicity, quality of life, cost effectiveness, and molecular markers, to identify molecular markers as the trans-SUPREMO in the local relapse and radiosensitivity. So in totality, they had around 1,600 patients, which were the chest wall radiation arm had 808 patients. No chest wall radiation had around 799 patients. So the results, which they have published at a median follow-up of 9.6 years, are suggesting that at 10 years, the overall survival of the chest wall irradiation group is around 81.4% versus no chest wall irradiation, which is around 82%. So there is no clinically significant difference between the two groups, though they feel that chest wall local recurrences were lesser, but again, they did not approach significance. So on subgroup analysis, they went on to say that they did not find any advantage of irradiation in chest wall irradiation in this subcategory of patients who had N0 disease or N1 disease. So they do feel that omission of chest wall radiation could be safe even for node positive patients. And this was their recommendation, that decision-making, the shared decision-making between patients and clinicians need to be done if you're planning to radiate patients with 1 to 3 lymph nodes in the intermediate risk category. However, like any other trial, there were certain criticisms to this trial as well, since it is spanning over a lot of countries. So there were questions about inconsistencies in tumor gradings and LVSI, and with almost 16.3% of node negative patients were deemed ineligible, raising concern about whether in the real world this study would be replicated. And they had a very less number of T3N0 patients, so we cannot generalize their findings on T3N0 to our clinical practice again. Third thing, which I think, which is, riddling any study which is spanning over 10 to 12 years, is that the changing and advancing systemic therapies and our practices in MDT have sometimes taken away the potential of the trials which are spanning over 10, 15 years. And even for the radiation protocols, they say that since it was such a large international trial over more than 130 centers, the radiotherapy protocol discrepancies and pathology discrepancies have been there. So these, I think it is not just this particular trial. For any breast cancer trial, when the trial starts, the treatment techniques are changing, our volumes are changing, our thresholds for doing RNI or IMN are much different than what we do now than what we used to do around 10 to 15 years back. And then definitely the role of systemic therapy cannot be underrated. Like, for example, when we talk of lymph node positivity in head and neck, things haven't changed. We know node positive, we have to treat. Beat cervix, somebody has node positive disease, we know we have to treat. However, in breast, node positivity has its implication, but the local recurrences and OS is not solely affected by radiation. There's a huge interplay of systemic treatment. So that is why these trials are getting difficult to interpret and directly apply into the clinical practice. So a trial similar to SUPREMO was done in a retrospective fashion by one of these groups, where they did post-mastectomy RT in 0 to 3 lymph nodes positive patients. And they have a very huge number of patients. So they included T1 to T2 N1 and T2 N0 and T3 N0 patients. And their endpoint was to seek the difference in overall survival. So this study had around 49,000 plus patients, of which around 6,800 patients had received radiation and around 42,000 did not. Though in their characteristics, there are a few things which need to be known, that T3 patients were more selected for PMRT, and more margin positive patients were receiving PMRT in their study. So in this particular retrospective analysis, they found that there was no significant benefit in overall survival by adding PMRT in this particular subgroup. However, when you go for the subgroup analysis of the 3 settings which we have included here, T3N0 subgroup did find significant improvement in overall survival by addition of post-mastectomy RT. So they found that in unadjusted 5-year overall survival also, they did not find any overall difference in the 2 arms where person is receiving RT versus not. So the only subgroup they found benefit remained to be the T3N0. But this again has the limitation by being retrospective in nature, and there is unmeasured confounding, and there is no recurrence in toxicity and quality of life metrics which has been analyzed. And there has been a lot of technical difference across the treatment delivery in these 6,000 plus patients as well. However, the conclusion which they did derive was that you have to individualize decisions, especially for T3N0 patients, take into account the patient's age, presence of LVI, and the ERPR and HER2 status needs to be taken care of. The second scenario, which I think is, again, as I mentioned, very important in today's context, is how to select patients for PMRT in 1 to 3 lymph nodes after a neoadjuvant setting. So as a running rule, it has been felt that you should use the clinical stage prior to neoadjuvant therapy as an indicator of your decision. And but there have been a lot of ambiguous studies which are saying that you should take into consideration the pathological response in the lymph nodes. If patient achieves complete response in the lymph nodes, you might benefit by omitting PMRT. However, if there is residual lymph node positivity, then you have to recommend radiation therapy. There is a study suggesting that if there is no residual in the disease in the lymph node, you can omit RNI and continue test for radiation. So this again is a big Pandora's box, and fortunately, there has been one study which at least has been studied in context of RNI. But let me just take you through a few different studies which have addressed NACT, post-mastectomy RT after NACT, which includes one of these studies which has taken into account around 24 studies, of which only one has been prospective. This is not particularly for early breast cancer. They took stage 2 and stage 3. But they did define that for planning adjuvant radiation, that is post-mastectomy radiation, you should segregate your patients based on risk factors into high risk category and low risk category. And the low risk category is the one where you might be able to omit radiation. These include patients who are older than 35 to 40 years of age, small tumors, T1, T2 tumors, where there has been pathological CR after the primary systemic treatment. So these are the group we actually are talking about. So let us see a few more studies in this respect. This one study by, again, Bookman, where they have analyzed the impact of PMRT in locoregional recurrence in patients who achieved pathological CR versus who did not achieve pathological CR. So if you see the box plot analysis on the left side, the first figure represents the patients who did receive radiation after pathological response in the lymph nodes. And the second box is representing the patients who did not receive radiation after pathological response in the lymph nodes. And you can appreciate very well that the patients who did not receive radiation had higher locoregional recurrence to the tune of 24.4% versus only 3% in the patients who received radiation. When we move on to the node positive disease, where patient received NACT, but the pathological response in the lymph node was not there, delivery of radiation increased the locoregional control by almost 46%. So patients who received radiation therapy had only 10.8% locoregional recurrences versus 56.25% in patients who did not receive radiation therapy in this scenario. So it is definitely an important finding that omission, many a times patient as well as sometimes our surgical colleagues, feel that if the patient has received, got a pathological CR, is there a scope of omitting PMRT in totality? This study does not support that. Similarly, this another study, this is from China. They retrospectively analyzed 185 patients in stage 2 and stage 3 who had no residual disease after mastectomy. And there they found that not delivering RT has given a non-significant trend towards a lower DFS and local recurrence in the subgroup of patients, especially if you look at stage 2, with the stage in question, where patients have received PMRT, the disease-free survival is 100% versus 84.9% in patients who did not receive post-mastectomy radiation. So there is impact of post-mastectomy radiation in this subgroup. And these are two more studies, one from Rusothen et al., who have analyzed around 10,000 plus patients in T1, T3 category, CN1, who received systemic treatment followed by mastectomy. Rusothen found that PMRT is improving overall survival in YPN0 as well as YPN1 category. In YPN1, it approaches more significance than the YPN0. However, they say benefit is in both the scenarios. Contrastingly, Overy et al. Have studied around 29,000 plus patients, in which around 62% patients did receive treatment. And although there are certain caveats in this, also in this analysis, there are certain YPN0 and N2 and 3 who did not receive RT, but they found that it is only N3 which mattered in their particular study. Similarly, another study by Spodden et al., where there was residual disease after systemic treatment, has shown that omission of PMRT did not worsen overall survival in their particular study to significance. Another study by Diaz et al., who studied around 116 patients of stage 2B, again, similar to our subgroup, in which 87% patients received PMRT. And they found that lymph node involvement does cause a poorer outcome. So there is a significant difference in locoregional control in patients who have lymph node positivity. This is a study by Kao et al., again, a small study by 88 patients, where they found that in patients with YPN0, adding PMRT has improved the 5-year DFS from 72% to 92%. The 5-year distant metastasis-free survival improves in patients who did not receive RT is 81 versus 92 in patients who received. The 5-year local recurrence-free survival, again, is better in patients who receive adjuvant treatment. So now, all these studies which I talked about were more so retrospective in nature. This particular study by the NRG Oncology NACBP B51 RTOG 1304 was the one which is prospective in nature. It is evaluating radiation therapy after NACT in patients who had node positivity prior to systemic treatment clinically and became node negative, that is YPN0 after systemic therapy. So their intent to evaluate was that they wanted to find if RNI improves outcome in breast cancer patients who initially had node positive disease and got converted into YPN0 after NACT. So they have divided the patients into if it is a chest wall radiation, they've divided it to chest wall RT versus no RT. If it is a BCS patient, then whole breast, followed by regional lymph node RT or not. So the intent was to find out the benefit of RNI. So their primary aim was to see the ipsilateral breast or chest wall recurrence-free interval in these patients. And there are a lot of secondary outcomes to be analyzed, like OS, the locoregional recurrence-free interval, distance recurrence-free interval, disease-free survival, including DCI, secondary primary cancers, cosmetic outcome. And also, simultaneously, they were trying to correlate the molecular subtyping, the impact of RT by the subtype of tumor, the molecular predictors for residual disease, and predictors for degree of reduction in local region recurrence. So they had a huge gamut of analysis to be done, and they selected almost all patients were enrolled. Their aim was to select around 1,600 plus patients over 15 years who belong to the category of T3, T1 to T3N1, had a lymph node positive on FNA or a core biopsy prior to initiation of neoadjuvant therapy, received neoadjuvant treatment or HER2-directed therapy as indicated, and after surgery, they wanted to see in the sentinel lymph nodes the presence of tumor, and only histologically node negative patients who became node negative after NACT were enrolled. So this year, their data on this analysis has been published. They have analyzed finally 1,556 patients, of which 772 received RNI and 784 did not. On a median survival of 59.5 months, they found that the primary events in the RNI and the non-RNI almost were similar, and they did not find any significant difference in the invasive breast cancer recurrence-free interval in both categories. There was no difference in locoregional or distant recurrence. There was no difference in the disease-free or overall survival. And they did not have any unexpected outcomes in terms of grade 4 toxicity also. They were low in number in both the categories, be RNI or be the non-RNI. So they conclude that we can omit RNI after neoadjuvant therapy in YPN0 category, as it will not increase the risk of death or recurrence. But clinical impact is that you have to personalize this treatment. So it has to be taking into account other factors which are yet to be defined in the NACT category. Another area of ambiguity is where patient has lymph node positivity, but it is either a micrometastasis or it is an ITC. So we need to identify the importance of the micrometastasis and the ITCs, which has been defined as less than 200 cells in the histological section by the AJCC 7th one. But it is believed that there is, as such, there is no consensus. But from the surgical aspect, the risk of axillary metastasis in patients who have had micrometastasis ranges from 9 to almost 57% across studies. But the surgical, bodies or the surgical groups are recommending that if you find ITC, you can get away with a full further axillary dissection, because they haven't found survival benefit in with or without axillary dissection in these two categories. But if you remember, if you see the ACOSOC 11 study, the occult metastasis did not affect OS because these are the patients who were receiving radiation therapy and incidental dose was going into the axilla. Few more studies are indicating the other way, that there is a worse disease-free survival and higher distant metastasis in patients who are even microscopically positive versus who have no lymph node disease. SEER database also indicates that as you see patients proceeding from N0 to N microscopic to N1, the survival incrementally does decrease. There is a mirror study which has shown that micrometastasis is associated with 10% reduction in DFS if systemic treatment is not advocated to them. And there is a systematic review on the micrometastasis also indicating that even tumor less than 2 millimeters is linked with a poor DFS and OS. So what should we be doing? So as of now, it is said that micrometastasis and ITC should be considered alongside other risk factors such as the primary tumor size, the grade of the tumor, and the HER2 and the ERPR status. And loco-regional management, as of now, they say should be considered similar to N1 disease. But this is still just I would say it is not a category 1 evidence. We are looking for more studies in these categories. But as of now, evidence supports that you can omit axillary clearance if it is a micrometastasis or ITC, and you have to individualize your decisions pertaining to radiation and systemic treatment. So based on all these studies which we have discussed, which I'm sure are confusing because sometimes some studies are depicting benefits, some are not. It is difficult to draw a lot of conclusions from retrospective studies. It is difficult to draw conclusions from study which have a very, very diverse population. So we need to have risk stratification. So this particular editorial, again by Putman, does say that you should consider these parameters when you are taking a call on PMRT. Young age, positive surgical margins, advanced stage, which is a well-known fact, unfavorable molecular markers like HER2 positive disease, triple negative disease, and high lymphatic involvement merits PMRT. Molecular profiling might help, the 21 gene recurrence score, although validation is still required to make it as a standardly used test. It might help us identify patients. This is a proposal. I won't say that you take home this as a message. This is just a proposal which I feel how things probably would, come to an understanding after we have the final results coming from more prospective study, that we would have to ascribe some scoring to all these bad risk factors, which I feel we understood from all the studies which we have, discussed today. The tumor size. I've mentioned 5 centimeter here. There are 2 studies which I've mentioned. It is a T2. And 2 centimeter is also of importance. Higher grade, presence of LVIs, surgical margins, age of the patient, and the ERPR and the HER2 status. So if we can ascribe scores to all these parameters, and based on the final scores, maybe this is how our PMRT practice might appear in coming 4-5 years, with more and more results, making the data on 1 to 3 lymph nodes PMRT more robust. As of now, this is how risk stratification has been considered by different guidelines. If you look at the NCC and the ASCO, they say that the intermediate risk group, which is defined by St. Gallen's tumors, which are N0 or are N1 to N3 with HER2 negative disease. If you go by the EVIC PMRT guidelines, they are recommending for T3N plus. For T2N1, T3N0, they say you should consider it. For T2N0, we will not be advocating RT. NCCN is considering, strongly considering radiation in the category of patients who are T1, T2, N1. And ASCO is recommending that you have to radiate patients with PT3N1 disease, but it is unable to recommend because of insufficient evidence. And this is how the NCCN stands in 2025, even after the SUPREMO and the other studies. And the 2025 guidelines are still strongly considering PMRT to chest wall and comprehensive RNI, including portions of axilla which haven't been dissected. So even after arrival of these 2 studies, as of now, NCCN, which were updated in somewhere in April and June, still is advocating PMRT. ASCO guidelines after 2016 haven't had much change, although the update which came in 2016 was questioning, had one of these key questions of T1, T2 tumors with 1 to 3 positive lymph nodes. So they say that generally we do recommend that you should go for RT in this subcategory because of higher risk of local failure and the impact on the breast cancer specific mortality. But do consider certain risk stratification factors, which include the tumor size, grade, LVSI, age, response to systemic treatment, and the number of lymph nodes involved. So I think we can summarize by saying that breast cancer is heterogeneous. Even in 1 to 3 lymph node category, it is not just one group. These are again patients with a lot of diversities amongst themselves. We are waiting for validated biomarkers, which we will be able to apply in our practice to make our decisions more objective in nature. Gene profiling, that is the DBCG RT, is showing promise in personalizing RT. And this is just a repetition of what I said, that NCCN is still considering PMRT. ESMO is recommending comprehensive nodal radiation as of now. St. Gallen says for 1 to 3 lymph nodes with adverse features, you should consider. So if you are in your clinic and your decision-making framework is showing a patient who is having a less than 2 centimeter low-grade tumor with left-sided tumor with a lot of comorbidities, ERPR positive, you can give consideration for deferring RT. But If patient is younger, has high-grade tumor, ERPR negative, HER2 positive, LVSI, positive margins, it has a right-sided tumor, inadequate nodal dissection, you should be considering PMRT. So to conclude, PMRT is reducing locoregional recurrences in cancer patients in 1 to 3 lymph nodes. OS benefit, though small, has been less consistent in the last 5-6 years of data set which is coming into our review. So individualized treatment based on clinical pathological as well as molecular factors is what is recommended. And I think we all practice the MDT whenever we are having such patients where you are considering whether the patient is falling into the intermediate risk category. You should discuss in the MDT and put all the things on table for the patients as well. So thank you so much for the patient hearing. Over to you, Dr. Aditya.
Thank you, ma'am. That was a very informative presentation covering all the data, like from the history till the time now. So we'll just see if there are some questions in the chat box. As of now, there are no questions. Ma'am, until then, I have a question.
Yes.
Like a postmenopausal woman, luminal A type, but she has like pathological T2N0 tumor, but she has grade 2 and LVI positive.
Pathological
T2N0.
T2N0, but
She has grade 2, like grade 3 and LVI.
grade 3 and LVI, they have given, I think one of the studies in the MVA found that ENE and grade 3 both are having significance. So there you would advocate PMRT.
Okay.
So, to be talking about real world practice, we all haven't stopped giving PMRT as of now. I know SUPREMO has shaken the radiation community early on, but as of now, I think the practice hasn't gone. And I think maybe few more prospective studies, with a more recent practice of radiation and more recent systemic treatment would be something which may make standard of care change, because NCCN has also not changed.
Yeah. And also, like in same scenario, like postmenopausal women, like pathological T2N0, but for which we have done oncotype DX, and she comes into intermediate recurrence score. So like, and we decided to omit the chemo. So like, should we consider her for RT, or like we can skip the RT also?
See, here is a patient who is not receiving systemic treatment as well. So I think here at least local control is of significance. So you have to tell the patient about the benefit in intermediate risk category, and particularly pointing out that there is no other systemic treatment which is being done, which might be contributing to local regional recurrence control. I think here I would advocate.
Like in the same thing, like we'll just do test wall irradiation or RNI also.
RNI is something which, based on this study which has come in NAGM this time, RNI, they are saying that you can safely change the volumes. Chest wall, they have continued. RNI, I think, based on the study, you can consider reduction.
There are no questions yet.
Your audio is also very, very low somehow.
Yeah, someone is actually typing. Yeah. How big does 21 gene assay change the decision making regarding PMRT in 1 to 3 nodes?
So we need validated, study for this. It is seeming promising. There are 3 publications which I came across which are trying to use it, bring out the generalizability to it. But I think as of now, still it is not something which is something you would be using day in and day out in your clinical practice. But surely, I think with more validated studies, maybe 2 to 3 years from now, we might be using it in decision making, especially since SUPREMO and the second study by the NACT study, these are giving us more and more prompts to use molecular markers. So I think once we validate these studies in clinical practice, this would be the way forward.
There are no more questions. Actually, this question was posted on YouTube channel. So just carry it out. Yeah. So I think like it's good to go now. Like We can wait for like 2 minutes if there are some questions
Sure.
posted.
Surely.
And there are no questions here.
Okay, and in case you need the presentation, do let me know.
Okay.
I'll be happy
On
to
this
share.
note, I would like to thank Dr. Kanika ma'am for giving us her valuable time and an excellent presentation. Thank you, ma'am.
Most welcome. Thank you. Good night, everyone.